gait report. And then they also get, like I said at the beginning, we do much more than the gait analysis. We'll do full history and look at shoes and range of motion and movement analyses. But just looking at gait today, we already went over this part. I want to talk to you a little bit about what these numbers mean. This is a work in progress. This is based on database of thousands and thousands of runners, male and female, all ages, put into one database. So already, based on the research we've been talking about, we know that's probably not the best way to look at data, right? It doesn't have a lot of control to it, right? But it's a work in progress that the University of Calgary is developing to come up with an injury risk. So the lower the number, the higher you are for injury risk. We usually see people, this is actually a fairly high number that we see in our lab. Dr. Ferber's tested a couple Olympians that are in the 60s, just to give you an idea. So it's very hard to get to your 100. I like to look at this not so much at the numbers themselves, because again, it's a work in progress, but the lowest number tells you the area usually of the greatest imbalance or asymmetry, okay? And so for Erica, your knees probably we're going to see a lot of symmetry there. And the ankle looks like the area we'll be focusing on, followed by your functional. I'll explain that in a little bit. But your hip and your knee look, and we'll look at it more deeply here, but look to be your strongest areas, okay? Does that make sense to you guys?
Ideally, you want the numbers pretty much the same, all for.
Ideally, you'd want, yeah, ideally, because remember, I think we talked about this in class, or maybe it was just in my own head, so forgive me if that was the case. But asymmetry, this was in 331, we talked about asymmetry being one of the strongest predictors for injury, that and previous injury. But asymmetry being a strong predictor for injury. So this report pulls out a lot of asymmetries. It also pulls out, I'll show you, high and low ranges of motion. So if you're really extreme motion on one limb or really low motion. So it kind of pulls out things on the end ranges of motion too, which I'll explain on these next few pages. Yeah.
Are these numbers based comparatively analyzed, or is it just sort of like through a program that just works on her strengths as in these four categories?
Yeah, so this is compared to that database of thousands of runners. Yeah. So not a ton of control. What Dr. Ferber would like to do, because he has now, it's not only our lab that's contributing to the database, he has about, I think, 15 other research sites, and we're all contributing. So eventually what we can do is really tease this out, males, females, different ages, and get a little bit more focused idea of what these numbers mean. Did that answer your question? Yeah. Okay. So what we see here, which is really cool that the software can do this so quickly, is it can take every stride she took in that couple minutes there are now averaged. And we're looking at her stance phase here. So remember this week we went over what stance phase is, right? It's heel strike to what? Toe off. So we're looking at, let's say she took 18 footfalls, which is usually about what the computer collects, 18 footfalls. This is taking the average of those 18 footfalls during her stance phase. You guys tracking with me? So all 18 stance phases are averaged in what we're looking at here, okay? Okay, and we have both her right and her left limb. Can you guys okay back there? Okay. And we have her ankle, her knee, and her hip. So this is her ankle. This is her knee. The right diamond is her right leg. The blue circle is her left. All right. Erica, do you want to write down anything as we go? Are you okay so far? Okay. Sometimes when people come in, they want to, because I forget when we leave. So, but there's sidebar here, there's a glossary too. And the glossary is written in layman's terms, because these reports are typically given for people that are coming in, off the street. So, all right, so we have the ankle here. Again, right is right limb, left is left limb. Going backtracking here, then you have the rows. You have excessive motion ideal motion, and reduced motion. All right? And again, this is based on databases of thousands of individuals, what would be considered ideal. I don't worry too much if both her limbs are very close to each other and they're excessive or they're reduced, as long as the right and left look similar. I don't get too concerned, just my personal view. But when you start seeing wide differences here, that's usually the area that I'd want to address first. So here are your dependent variables. Dependent variables means they're what? What's another way to describe a dependent variable? They're changing because they are... How do you identify dependent variables? It's something you can measure. Yeah, good. I didn't state my question well. Right, something you can measure. So here's our dependent variables. Peak pronation, pronation velocity, time to peak pronation, peak tibial rotation. Remember we talked about the tibia rotates with as you pronate. And then rotation velocity is of the tibia as well. So if we look at her peak pronation, what do you guys notice is happening? One side's a little bit happening, much more pronation during stance phase than her other side. So your left foot is pronating more than your right. Okay? But they're both pronating at the same speed. Okay? So one's pronating more, but they're happening at the same velocity. Time to peak pronation is how quickly you hit your max pronation. So again, they're both pretty much hitting max at the same time. So they're moving in the same with the same velocity. Your left is just moving a little bit more in regards to pronation. I'm glad this happened on this report because this is easily explainable, which is good for class. What do you notice about her tibia?
One rotates more than the other.
Which matches her foot pronation, right? So the tibia is following, as we learn in class that often happens, because her left is pronating more, okay, her left tibia is rotating more. Rotation velocity, again, is very similar. I'm not too worried about that. So the speed at which your limbs are moving is fine. You just have more motion on your left side than your right. Your right side's your painful side, right? Okay. Any questions about the ankle? Your knee looks great. Okay? Yeah, yeah. One of the first variables I look at with a patient is peak knee flexion. This means how much flexion she's getting during the stance phase. If a person has pain, what do you think happens to their knee flexion every time they land? Just think about it. If you're in pain.
Increases. Well,
Opposite.
decreases.
Decreases because you're what?
The less time on it.
Oh yeah.
You want less time on it, right? So you get stiff.
I think I'll fall.
Yeah, yeah. Yeah, just give out, right? When you have a lot of it. So her peak knee flexion, it couldn't be any better. It's pretty ideal on both sides. So she's trusting her body, which is good. Marissa asked you this. I didn't hear the response. Were you in pain with that short jog? Okay. No. Okay. So peak knee flexion can tell you a lot right away about if they're bracing or not. Going backwards, starting with our first dependent variable here for the knee. Peak knee collapse, what do you think that's measuring? Jenny, what? Valgus. Okay, good. Ideal on both sides. Very good. Knee collapse velocity, how quickly you're moving into valgus. Pretty close. Right and left. And ideal. Peak knee rotation. Similar to her feet, we're seeing a little bit more knee rotation on the left than the right. So that means collectively when you look at the tibia relative to the femur, it's moving a little bit faster inward. Okay. So this is the femur relative to the tibia is moving a little bit faster. This is the tibia up here. So the femur is following the tibia, which Again, we learned in class, often happens. It doesn't always look this clean. Thanks, Erica. You've been great for class purposes. But you see a theme here of more left side versus right side motion. The trick is, as a clinician, is it good that our left is this high, or is it good that our right's this low? How do we bring them closer together, right? Do we increase motion on one or decrease motion on the other? Those are things you have to start thinking about as clinician. The main point being we want them closer together, and we'll get to how to apply it here shortly. Questions on the knee? Hip. All right. We have a change. What do we notice with peak hip collapse? Is femoral what? What do you think?
Adduction.
Adduction, good, Mike. Okay. What's happening here?
The right one is got too much.
Yeah, we've got excessive motion. Yep, hip adduction. Yes. The femur internal rotation is the fine on right and left. When she's on her right side, this means when she lands on her right, her left side is dropping, which goes along with hip adduction on the right. Lots here, okay? The amount of extension on the hip you get is very good on both sides. Functional outcomes, this is stride width, stride rate, toe out position, and heel whip. Stride width, stride rate, right on top of each other, right and left. A little bit more toe out on the left, which actually goes along with having higher pronation on your left, but they actually reduced. Both of them are a little bit reduced. And then the heel whip I'm not worried about. That's how much torsion you have happening when your foot comes up off the ground. That looks pretty good. Questions before we get to what does it all mean? How are we on time?
150.
Oh no! Okay, all right. I'll be. Who needs to go? Okay, that's fine. Nope, that's good. Maybe I'll post it on Blackboard if that's okay.
Yeah.
Okay. Christy, I'll get the video to you. What the last thing we talked about? My apologies, you guys. I rarely keep people late. I'm usually on time. All right. So what does it mean? If you guys want to go or need to go, feel free. But we'll try to be brief here. It looks like your left side, as we talked about, you have more foot and tibial rotation on your left. And possibly because of that, okay, and then on your right, at the hip, you have more motion, right? So I don't want to say because of. It's hard to know if the chicken or the egg comes first. One hypothesis is that because you have more motion when you land on your left, then when your right comes down, you might land a little bit harder, and then your hip's not supporting that on the right. Does that make sense to you guys? Okay, you guys track with that? So if she has more motion on her left, potentially she's coming down when her right hits, she's just hitting a little bit harder.
You're dropping on the left more than.
So then you drop on the left, right, because your right hip's not supporting you, because your left is pretty mobile. What would you guys suggest? Now remember, usually we have a lot of other information, we just have gait today. How do we bring these closer and these closer?
They have to treat the problem first, right?
Treat-
Deal with the pain.
Yeah, we have to think about it. She's definitely still in pain, but this might be part of why, right? So maybe this would be an avenue at getting at treating that.
Maybe some hip strengthening.
Okay, we could work on some hip things, right? Yeah.
Because it's the right hip that has excessive and leads to the left pronation of the tibia and the pronation, so it's not supporting the the other side, so.
Right.
Just, or it can be the other way around.
It can be the other way around too.
So depending on muscle testing, which
Yes,
size,
yes,
which
yes,
size and
yes.
work either up the chain or down the chain.
Yep, we would want more information,
Yeah.
for sure. Yeah. Do you have calluses on your feet? No? Okay. Any other thoughts or questions you would have? Or how you might approach this?
Might do some range of motion.
Yeah, we'd want to know what's going on. Why does she have more, what looks like motion here, right? Definitely want to know some range of motion. I would probably do it through our FMS, through our goniometry, things that you guys have learned, right?
I think I'm pretty similar.
Yeah, that's good. You sense that you are, which is good. So do
We've
you,
done it.
do you feel like it's a strength issue?
Probably.
Okay, and that's always good. You want to take the patient feedback too, right? So things you would then also look at is her foot tight posture. Do you have flat feet, high arches? Do you know? Okay.
Yeah.
Yep, you'd want to look at that as well.
How do you buy the shoes?
What's that?
Who bought the shoes? I mean,
You want
how
to
do
look
you-
at the shoes,
Yeah, I
right?
mean, if you bought it because you like them or because those were the shoes that you needed to run
Absolutely.
with.
Did you get fitted for your shoes? Yep, so that might be one of the first places I would suggest is a shoe store fitting, like a running shoe store fitting.
Definitely need new shoes.
A neutral, I'd start with a
Yeah.
neutral shoe, okay?
Check out the bottom of the shoes where it's going.
Check the bottom of the shoes and see where the wear pattern is. Can you see?
Left to right.
Soup. Looks like supination.
Oh, you're
Another here.
Yep, on the outside part. That's why you're collapsing into pronation. See how she's got wearing on the outside lateral part?
Mhm.
So that she's just collapsing into pronation a little bit harder. One idea is some eccentric work at the pelvis and the hip and the low back to control that down. We can talk about ideas when class is over. That might help with some of the collapsing. Or you guys could, after you have your full assessment, start more at the foot up, right? Everybody's about the hip, so I think we need to think a little bit more too about that. I think we need to be thinking about low back, how that connects to the pelvis. And you could start again. You could also want, like I said, start at the foot, the tibia. Is she controlling? Remember what muscle was on in EMG the whole time? And our
Anterior
anterior tibialis is on the whole time, right? So does she have eccentric control of that in that anterior tibialis, right? That can play a lot. So how's her eccentric strength, the anterior tibialis, soleus, posterior tib, gastroc? We'd look at all of that as well. Okay? And so it'd be a very holistic approach, but using this to kind of guide that can be really helpful. Does that give you enough kind of clinical insight into how you would go from where you would go from here? Okay. So what I'd like you guys to do is with the questions I put on your notes today, just bring them with you on Monday to class. I'll take a look at them then, and that way you can have some time to think about it. It doesn't have to be long answers, so you can just bring them with you on Monday. Erica, if you have time to stay after, we'll go over some specific ideas with you. All right. Thank you guys for staying a little bit later. I apologize for that.